We're going to go ahead and get started just to be mindful of everybody's time. Good afternoon, everybody. My name is Victoria Tyra, and I am the Education and Communications Manager with Michigan Center for Rural Health and will be facilitating this program. I would like to welcome everyone to today's Psychiatric Grand Rounds on the psychiatric impact on the cannabis use of during adolescence. This program is jointly provided by the MSU.
That's what I was kind of thinking, but
the MSU College of Human Medicine, the Michigan Center for Rural Health, MSU College of Nursing, and the Michigan Social Work Collaborative. Before we begin this program, just a couple of reminders. If you are logged into the webinar and have computer speakers, you can listen to the audio through them. If you're listening to the program through the audio number, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across the top, scroll down, find Grand Rounds, and then scroll down, find today's date, and then there you will see the presentation link. Continuing education is available for physicians, nurses, and social workers at this time. Please note that there is a new process. There is no attendance form. Your registration was your attendance form. The evaluation will be emailed directly to you following the program. If you attended in a group, please send me a list of everyone that attended at your site, first name and last name, and your email address so that everyone that attended at your site can get the evaluation link. The evaluation must be completed online, and the forms must be completed within 2 weeks or by December 22nd. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support with this program, and I'm pleased to introduce Dr. Lay, who is with the Department of Psychiatry at Michigan State University Department of Psychiatry. Go ahead and take it away.
Yes, thank you, Victoria. I'm a child and adolescent psychiatrist. I'm the associate chair of our department, as well as the director of the Child and Adolescent Fellowship and the Adult General Psychiatry Residency. But beyond that, I do practice at Community Mental Health. I teach residents and medical students, and I have my own clinic.
Hey, I found it.
With a focus on child and adolescent psychiatry. So I'm going to talk to you today a little bit about what we're seeing and what's going on with cannabis in adolescence, and we'll go from there. So this is a case I wanted to start with because it's sort of a conglomeration of what we're seeing, okay? And we're seeing it quite frequently, and we're getting lots of referrals for kids that look similar to this 15-year-old who may have presented to the emergency department because she was going to the primary care physician. Sometimes she presents to the emergency department, or sometimes it's as a referral to our clinic. But the child has suicidal ideation, depersonalization, feeling though she's outside of her body, feeling as though the world is not real, derealization, some confusion and paranoia are the main complaints. The suicidal ideation is what got the kid into the emergency room. Her mother reports that she began having these symptoms about a month prior, and they were associated with irritability, anhedonia, or a decreased ability to experience pleasure or enjoyment in life, and a lack of energy. This kid was formerly a straight A student. Now she's failing 2 of her classes due to what she says, no motivation. She's no longer attending to her grooming and hygiene, has gained weight, and this is due to eating more because of an increased appetite. So what I want to point out in this is there are many psychiatric conditions that you're going to start thinking about. Oh, does the kid have ADHD? Does the kid have anxiety? Does the kid have depression? But when you look at the whole picture and the constellation of symptoms, this has to be, for various reasons that we'll go through, a cannabis use disorder. It should really be high on your list, thinking about cannabis use disorder in teens when any teen presents with any type of psychiatric complaint. And we'll go through why. Okay, so cannabis The main two forms of the plan are cannabis sativa, which is advertised as being energizing and uplifting, and then cannabis indica, which is more sedating and relaxing. So if you go into a dispensary, they'll say, what type do you want? And then there's all different variations within these two. The plant itself contains over 500 natural compounds. The psychoactive ingredient, the thing that causes the addiction and the psychiatric symptoms, we believe is THC, but there are 500 different natural compounds. Not all of them have been studied, and we certainly haven't studied this in adolescents very well. So comes in many forms. There's the dried plant that's often smoked. There are edibles. Edibles have become, as we've moved toward legalization, edibles have become more common. Edibles are sold at dispensaries and things like that. Often they're in baked goods, beverages, candy. So what's sort of the issue with edibles, especially with teens? Well, it takes longer to get the effect with edibles. So sometimes, and lots of times in the studies, what we find is the doses are much higher that people are actually consuming with edibles because it takes some time to digest and metabolize and to get the THC into the system. There are extracts or resins that can be extracted from cannabis in different ways. These are called oil, wax, shatter, butter, and these are used as well, and they're nearly pure THC. The content is extraordinarily high in these, which is, we'll find that the psychiatric symptoms that occur with these sometimes are almost immediate. And lots of sort of psychotic symptoms can happen in the vulnerable individual. There are also synthetics, most commonly K2 and spice, you'll hear kids talk about. These have extremely high potency, and they may be more dangerous because of the high potency. That's up for debate because lots of times the dried cannabis, any of the edibles are also contain K2 and spice. Nothing is really quote unquote pure anymore. Things are sprayed with lots of things, and there are things added to increase the high or the state that one wants to be in when using cannabis products. This is sort of an important thing to think about. When I meet with parents, they'll say, yeah, well, we've all tried pot. Who hasn't? You know, what's the big deal? Is there a big deal? The truth of the matter is the content of THC has increased dramatically from the 1970s. So, and these are in studies by the National Institute of Drug Awareness, taking random samples and looking at the amount of THC content in an ounce or half an ounce or in their standardized form. And what they found is we've gone up from about 2% to 20 to 25%. So this is not the same cannabis that used to be smoked. This is not the same marijuana. A few words on CBD. CBD is the other large component that's used, and we've talked about its medicinal properties. This ingredient may have the most medicinal properties. It may have the most medical benefit. It is not psychoactive, although CBD that you buy may have traces of THC in it, depending on who is producing and how it's distributed. So it's important if you're using CBD to look at that. We've had adolescents insist that you're using CBD oil and have tested positive for THC. Whether or not the product had the THC in it or they were also using other forms of cannabis remains to be known. The potency, interestingly, of CBD in contrast to THC has remained about the same over the last 30 years. So because it doesn't have a psychoactive component, the street value of CBD hasn't prompted a change in the amount or strength of CBD. So 35 states have legalized marijuana. use in at least some form. 15 states, including DC, have legalized for recreational use. You can see those in brown. 20 states have legalized for medical conditions. So as things become more legalized, young people believe that if this is medical, then it must be good for you. Certainly, we have to have true conversations with kids about this. There are lots of things that are quote unquote medical that do not mean that we can just use at will, and things that are medical can be addictive. Okay, so because of this medicinal and recreational use, we have increasing acceptance by and large, especially in teens, and like I described, teens are thinking that this is not a bad thing and that this is a natural thing and this is better than other drugs. So what we do know is since we sort of attacked the opiate crisis and exposed it, the amount of opiate use is decreasing. Now, the number of deaths from opiate use continues to be pretty steady, but marijuana has increased, and visits to the emergency room prior to the COVID pandemic were increasing. Any policy that's made regarding cannabis and legalization thereof is based on any limited research we have in adults. We don't have great research because this cannabis is a Schedule I controlled substance. And so a lot of research was prohibited for a long time. We're starting to get that research now, less so in children and adolescents, more so in adults. So we need that research. These are just some of the advertisements just in Lansing for medicinal marijuana. These are signage that's outside of dispensaries. In adults, it's talked a lot about to use cannabis for pain management. The verdict is still sort of out on that. There are very few quality studies in adults that really are well designed with regard to pain management. And there's so many comorbid medical conditions as well as multiple medications prescribed that the studies are somewhat hard to do. In the few that we have, it's hard to demonstrate that cannabis by itself separates out from placebo. So the difference between placebo and cannabis, it's hard to determine that. And it doesn't appear, at least in cancer patients or people with severe chronic pain, to be a good substitute instead of an opiate. And that was a big push, that maybe we could use cannabis instead of opiates and lower the rate of opiate abuse. We are lowering the rate of opiate use and opiate use disorder since 2018, but cannabis is increasing. We're doing that by education alone and treatment programs. Okay. It's important to also recognize this whole idea of natural. Cannabis is natural. Kids will often say that it's good for you. I can show you all the websites. It's good. It's going to be great. Well, we just don't know yet. But in looking at Dryberg and colleagues did a very interesting study, and they just looked at the number of contaminants in random samples of cannabis bought at dispensaries. And what they found was a high percentage of those samples contained bacteria and fungus. Salmonella, Enterobacter, Streptococcus, Klebsiella were the ones that were most commonly found, as well as Aspergillus. It's believed that this is that these contaminants, these bacteria and fungi are infecting or are contaminating the cannabis because of improper preparation and storage. There's no regulation of how cannabis is harvested, stored, prepared, and so we're getting some contaminants in there. Aspergillus produces an aflatoxins, which could be carcinogenic. That's an area of study right now in by Dryberg and his group. Also, heavy metals are found, organophosphates, things in fertilizers containing cadmium poisoning. We've got to worry about high levels of cadmium. Cross-contamination during processing, we think, is what's happening. The cannabis plant does a pretty efficient job at absorbing metals from the soil. We also have some individuals that will add metals to the processed marijuana or cannabis in order to increase the weight so that it can be sold for more. And there have been several cases, as you can see, of lead poisoning that have been traced back to this. Pesticides also, like you mentioned, organophosphates, insecticides, fungicides, miticides, and up to almost 85% of those random samples tested in Washington State showed pesticides. So natural, maybe not so natural. Use in teens, and that's what we're here to talk about today. Use in teens is sort of exploding. It's becoming a very, very common phenomenon. So if we look at just overall the world population, about 4.8%, 20% of adolescents have used or tried cannabis in the past month. And this is all the way from age 13 to 18. Who uses it daily? We have about 5.8% of 12th graders. And as you can see, the older the child or adolescent gets, the stronger the chances that they're using. And that's a good percentage. And about 1.5% of Americans overall. So just to review intoxication and withdrawal, what symptoms do individuals have when using? And these are the most common symptoms, include a brief period of euphoria. There can also be anxiety, disinhibition, or an impact on our judgment, paranoia, time perceptual differences, time passes in unusual ways. Individuals will feel like they've spent just a very little time. It'll be hours later. You'll see conjunctival injection or red eyes, social withdrawal, increased appetite, which leads to increased eating in a binge type manner, and often weight gain. Individuals will have dry mouth. Hallucinations can happen, both visual and auditory, on cannabis alone or cannabis plus synthetics. But now we used to just see sort of hallucinations and psychotic symptoms in, I'd say 10, 15 years ago, in people who were using cannabis and other things, or cannabis laced with something. Now we're seeing in what people believe to be just their usual marijuana that they buy. Amotivational syndrome. Amotivational syndrome is, just as it says, a lack of motivation. And you see this with daily use, even after a few months of time, 1 to 2 months, you'll see that there is a lack of ability to initiate new projects or to complete things, or even gets to the point of getting out of bed, or really doing any sort of activities of daily living, or things that you don't, but becomes very difficult, especially for teenagers, to start projects. And that's why we often see this decrease in grades, especially turning in homework and performance. There's also a syndrome that has come to light, I'd say within the last 5 years, called a hyperemesis syndrome. And what we'll see is people usually who smoke, and we'll talk more about this, daily or chronically, will develop cyclic vomiting. And it's associated with abdominal cramps, sometimes relieved by unusual things like getting in the shower. We'll talk about that. In withdrawal, there is withdrawal from cannabis and marijuana. We used to think that there was not. We used to think it was not addictive. I think it's been shown now, and we'll talk more about that, that it is indeed addictive. But what you'll see in withdrawal is a significant amount of irritability. You'll see also depression. You'll see insomnia, and that can be early, middle, or late insomnia. So having trouble falling asleep, having some early morning waking is also common. Also, you'll see nausea and withdrawal. You'll see appetite decrease substantially. Usually withdrawal peaks within 48 hours, especially for cravings. But it can last, these acute symptoms and the severe symptoms can last for up to 5 to 7 days. Remember that THC is detectable in the urine for up to a month after the last use. So it stays in your hair for a long, long time, and probably likely your brain for up to 6 months. You may have some protracted sort of withdrawal symptoms. So what are the consequences of daily use? The consequences of daily use is the possibility of addiction. There is some literature on increased motor vehicle accidents in people who are intoxicated, even in people who were using and are not intoxicated, teenagers who are not intoxicated at the time of an accident. I have a slide or two on that in the future. Chronic bronchitis, the EVALI syndrome, or the e-cigarette vaping associated lung injury. And before COVID, this was a big topic. The CDC was putting out lots of information regarding individuals showing up in the emergency room, and 68 individuals dying due to vaping products with both vitamin E and THC. How much THC is implicated in that is unknown. Weight gain, neuropsychological decline, which is what we're going to sort of focus on, and cyclic vomiting. So for the treatment, we get this question a lot as psychiatrists. So what do we use cannabis to treat of psychiatric conditions? I would say that the majority of individuals that people see in medicine will tell you that they're using cannabis because of anxiety, or they're using it because of depression, or they're using it for PTSD, or they're using it because their ADHD medications make them feel too jittery, or for some other reason. A lot of those reasons are for mental disorders, but there is no evidence to suggest that cannabinoids improve most mental disorders, including depressive disorders, anxiety disorders, or ADHD. As a matter of fact, in teens, it likely makes it much worse, all three of those. So we need more studies though, and like we mentioned before, those are hard to do. So the American Academy of Child and Adolescent Psychiatry came out with a few statements in 2019 that I think are important for healthcare practitioners to know when treating teens and discussing cannabis with them. It's important to remember that recreational marijuana use, although legal in many states for adults, is not legal anywhere in the United States for children and adolescents. The reason for this is we don't have research supporting the use of medical marijuana or marijuana for medical purposes in teens. It's not regulated. As you can see, there are contaminants. We don't know who we're buying this from. Like other controlled substances, we don't know how much THC you're getting, if you're getting other things, the interactions with other medications we may be prescribing. So because we don't know purity, strength, safety, we cannot recommend it for any condition. We do know CBD is approved for epilepsy, certain type of epilepsy in children, and for adults in chemotherapy. There's been a medication for years that has been used for chemotherapy, which is an extract of THC, but it's not used very often because there are other things that are better, other medications that work better. So what we do know is that adolescents who are using are and we need to consider them an at-risk group, right? They're at risk for many things, but those two big ones are cognitive impairment and psychiatric morbidity. Either they're using the cannabis to treat themselves, their psychiatric conditions, or they're developing a psychiatric condition from chronic use. So there's a strong correlation in many studies, and Levine's study was in JAMA Psychiatry, between teen cannabis exposure and persistent negative neuropsychiatric outcomes at the time and also in the future as adults. So we're in the infancy of looking at MRI changes in the brain. And what we've discovered is there is some increase in gray matter density in the brain, in the temporal lobe, the posterior cingulate gyrus, and the cerebellum. What does this mean? We're not 100% sure, but what we do know is during adolescence is a time that our brain is developing almost as fast as it did when we were in infancy and toddlerhood. And what the main sort of goal of the brain at this time is to prune, to make the brain more efficient, to get rid of the excessive sort of neurons and to make sure that we have what we need to efficiently run our systems, right? And what seems to be happening from a very gross generalization sort of standpoint is that cannabis is entering the brain and confusing that system or slowing it down, and we're left with increased gray matter density. We also look and we see decreased volumes in the hippocampus, the amygdala, and the prefrontal cortex. Prefrontal cortex being the area of the brain that is used for organizing and planning. The amygdala and hippocampus, the areas that lay down memories and emotional memory and things like that. That's why with people who've smoked chronically, you may see sort of a flattening of the affect. So maybe attributed to those areas. Gray matter volume. This is an interesting study. It was in the Journal of Neuroscience in January of 2019. It compared 46 14-year-olds with and without cannabis use. And it did indeed say that the findings from the last, the increased gray matter density findings were indeed true in this cohort of 14-year-olds. So what do we know from a psychiatric standpoint? We know that cannabis induces and exacerbates many, if not most, psychiatric conditions, including all of these: anxiety, depression, psychosis, amotivational syndrome. It can happen in psychosis, depression, anxiety, but in amotivational syndrome in and of itself is attributed to cannabis abuse. Problems with concentration, working memory, processing speed. This issue makes it very difficult to diagnose and to treat ADHD if someone is also using cannabis. We can have paranoia, hallucinations, which can go with psychosis, or they can be on their own. Panic disorder, either in intoxication or withdrawal. There's an increased risk of violence and aggression, probably due to the disinhibition. There's reduced school performance. Overall, if you talk to individuals who smoke on a daily basis chronically and you follow them throughout life, you will see that approximately 10 years after using, there is a reduced life satisfaction on scales of life satisfaction scores, and it can increase impulsivity. So this again is Gobi. He and his group did quite a few studies looking at the neuroanatomic differences in the cannabinoid receptors. And what is happening is there's a decreased volume of these cannabinoid receptors in the hippocampus, amygdala, and prefrontal cortex. And what we're thinking that's doing is increasing tolerance and sort of downregulating these receptors. So, and also along with that, so that's making addiction a higher possibility. We're also seeing, and in this study, there was a higher risk of suicidal behavior in these teens that were being studied, and a younger onset of psychiatric disorders. They may have had a predisposition to psychiatric disorders. there may have been a chance that they were going to have those anyway, but it seems to be happening at a younger age if using cannabis. Their recommendation is quitting cannabis by delaying the start of cannabis as long as possible is going to be what we would try to do with adolescents. And the earlier you quit, the better. But one of the sort of significant findings was that even if you quit at the end of adolescence, there may be some effects on the brain. Okay, so what is the risk of addiction? We now call, ever since the DSM-5 came out, we no longer call it cannabis dependence. The name has changed to cannabis use disorder, which is like alcohol use disorder, cocaine use disorder, opiate use disorder, which is dependence. What you'll see is physical dependence. You know that because you'll see cravings, going to extraordinary measures to obtain the substance, intolerance, use of more and more or more frequently. You'll also see the withdrawal symptoms, the irritability. You'll see insomnia, decreased appetite, anxiety, cravings as well. That should really go in the dependence category. The risk of addiction is about 10%. In studies, it ranges anywhere from 9 to 30. National Institute of Drug Awareness is going to give you a figure of about 10%, which is equal to the rate of addiction of alcohol. So it's we think as addictive as alcohol. Use before age 18 increases the risk of cannabis use disorder, cannabis dependence 4 to 7 times. So again, we're recommending delaying the onset of trial of cannabis. So this is back to the gateway hypothesis that we often hear about. You know, marijuana is a gateway drug. What does that mean? People say, oh, that's nonsense. There is some evidence, and these are sort of retrospective studies in individuals with cocaine, methamphetamine, and opiate use disorders. What was the first drug that you used? And it was cannabis. So now we've gotten a little more sophisticated than that, and we've been able to look at what is actually happening. And we do think it may be this sort of down regulation of the dopamine receptors in those areas of the brain that is causing individuals to seek more and more. So we're seeing that in the remember, dopamine is the neurotransmitter released when using psychoactive substances. It's the neuro substance that is increasing the likelihood of addiction, causing the good feelings, causing the euphoria. So with downregulation of that, it's increasing tolerance, or you need to use more and more of it. And that's not only happening with cannabis, we don't think, but it's happening for other drugs. So morphine, cocaine, amphetamines, making maybe the gateway hypothesis a truth, and increasing the likelihood of using higher amounts of opiates, cocaine, amphetamines, other drugs. Okay, it's important to remember, and that cannabis, even though you have the two different forms and the one's supposed to be more stimulating, it's a central nervous system overall depressant. There was a study in Lancet in 2017 of monozygotic twins, and they found monozygotic twins, some who smoked, some who didn't use cannabis, and there was an increase in major depression, an increased risk of suicidal ideation in the twin that was using cannabis. And we talked about Gobi's trial too. So depression, so just to take some of these psychiatric disorders out and look at them individually. Depression, what we see in either an individual who presents with depression, who is using cannabis or started using cannabis and then has depression, or started using cannabis for the depression, is we see an increase in symptoms such as anhedonia, the inability to experience pleasure. We see low moods. We see the amotivational syndrome, changes in appetite, sleep disruption, and suicidal ideation. Suicidal ideation, why is that occurring? Why is it more frequent? Well, it could be due to the disinhibition, or it could be due to the neuroanatomical changes in the long-term sequelae. It could be because it's worsened depression And suicidal ideation is one of the common symptoms in major depression, but we're seeing that. With anxiety, what we see is cannabis increases panic attack frequency. It can, depending on many individuals say, not most, but many individuals say that their first panic attack happened while intoxicated, but it can happen in intoxication or withdrawal. There can be some rebound anxiety when the cannabis is coming out of your system. And for somebody who's sensitive to that, that can even lead to panic attack. And then this feeling of depersonalization, derealization, both in intoxication and withdrawal, but in some individuals who are highly anxious, these symptoms can persist even when the cannabis is out of the system. You can have this feeling of sort of detachment. So cannabis and psychosis has probably been the most widely studied area in the past in adults. It's been long known that cannabis worsens psychosis, but there's been a debate as to whether it causes psychosis, and it's a chicken and egg phenomenon. Are people who are predisposed to psychosis using cannabis because of these underlying sort of prodromal symptoms, and that's leading to an onset earlier, or causing the onset, or is it causing it altogether? What we do know is that cannabis does lead to an increased risk of development of a psychotic disorder. It leads to the increased risk of earlier onset of that psychotic disorder as well. During use, we see delusions, we see paranoia very, very, very frequently, even in people who are not going to develop a psychotic disorder. But you can develop a brief psychotic disorder. All schizophrenia starts out with, and psychotic disorder, schizophrenia is the most well-known, but it all starts out with a brief psychotic disorder. Those are psychiatric symptoms, including positive and negative symptoms, hallucinations, delusions, disorganized speech, disorganized behavior for approximately a month. That's brief psychotic disorder. From 1 month to 6 months, we call it schizophreniform disorder. And then after 6 months, it becomes schizophrenia. So what we do know that there is a cannabis-induced brief psychotic disorder. So people will have the symptoms for a month. If they stop using, they may never experience another psychotic episode or a chronic psychotic disorder. And then there is cannabis-induced psychosis. And I've seen several cases that have ended up in the emergency room here locally of severe sort of psychosis where teens have been using cannabis. I had one teen who switched from indica to sativa type and developed severe psychotic symptoms. What we do know from the research is if an individual has psychotic symptoms in either intoxication or withdrawal from cannabis, there is a higher risk of developing future schizophrenia or chronic psychotic disorder. So up to 75% of individuals, like the individuals I have seen in the ER, the rate would be the risk is about 75% of those that they have studied who've ended up with a brief psychotic disorder or psychotic symptoms will end up with a chronic psychotic disorder such as schizophrenia. We think that the more an individual uses, the higher the risk. It is highest in all the studies in those with a genetic predisposition, but remember, most people with schizophrenia don't necessarily have a genetic predisposition. But it was also found in individuals without that predisposition, about 2.2% increase compared to the general population. So it seems like if you have these symptoms, it is a red flag, and this person needs to be watched very, very carefully and be treated by a specialist and monitored closely. So then the big question is, and has always been for many years, does cannabis use actually cause? It's very difficult to demonstrate a causal relationship So what we say is heavy use of cannabis is more likely seen in individuals with psychosis. We know that. Even individuals who have psychosis and did not use prior to developing schizophrenia or psychotic disorder, the use, it's often seen that in just the entire population of those with schizophrenia, there's a higher proportion who use cannabis on a regular basis. Psychotic disorders are more common in cannabis users than non-users. In cannabis users with psychotic disorders have what we know at least, we have been able to demonstrate in the literature, an earlier onset of the psychotic disorder symptoms. So especially when you're dealing with people with a genetic predisposition to psychiatric conditions, this is an important thing to know, that it can lead to earlier onset of severe chronic mental illness. Also, in individuals who have schizophrenia who are using on a regular basis, they have a higher rate of relapse of psychotic symptoms. They have more hospitalizations and prominent positive symptoms. The positive symptoms, again, are like the delusions and hallucinations. So it seems like there's a dose-dependent risk. The higher the level of, the more you use, the more likely and the increase the risk of psychotic disorders. And then high potency, like we talked about the butter, the wax, those things, and synthetics carry probably the greatest risk. And what else would we say that? Okay, and in some studies, up to 5 times the risk for daily users of developing a psychotic disorder. ADHD, as a child and adolescent psychiatrist, ADHD is one of the most common things I see, or that is referred to me. It's really difficult to make a diagnosis of ADHD in an adolescent who has not had a diagnosis prior, because the symptoms so overlap. And also because the effects of cannabis intoxication, right? We know that it affects working memory, processing speed, IQ. So it's very hard to determine if the symptoms that individual is experiencing are indeed ADHD, or is this due to the cannabis? Neuropsychological testing, so that's often brought up. Well, so we get neuropsychological testing. It's going to be invalid if someone is using. And I would say if they've been using it over in the past month, it may be invalid, and it would probably be even best to do that neuropsychological testing, if that's what you would like to do, 6 months down the road. Remember too that stimulants, which are the gold standard for the treatment of ADHD, are controlled substances. And so there's this potential for abuse. It's difficult to monitor whether the stimulant's working or not if you're using cannabis as well. And we do not start controlled substance with daily frequent use without agreement of cannabis discontinuation. For all these reasons, we just can't really tell what's going on. There is a study by McCabe and Associates that, and we do know this, that if you diagnose as a child, a young child, ADHD, and you put that child on a stimulant medication, it decreases the chance of developing a substance use disorder, including cannabis use disorder. So we do know that. So treating ADHD at a young age is important to identify these kids, to treat them, to use stimulants, because it will lower the chance of developing a substance use disorder. However, if somebody shows up, they don't yet have the diagnosis, and they have new symptoms, it's going to be hard to tell whether or not they have ADHD. So this is just a depiction of that. So how do we tell these two things apart? So ADHD is a neurodevelopmental disorder. You're born with it. It's got to be present and impact your functioning by age 12. If it doesn't impact your functioning, it is not ADHD. It persists in all environments. Again, it's a neurodevelopmental disorder. So this just doesn't happen at school or on the soccer field or at home. It has to happen in all those places. There's no change in energy in people with ADHD. Either they're high energy, hyperactive individuals, or not hyperactive individuals, because you can have the inattentive type, but you don't see this fluctuation in energy and motivation. It's pretty static. And there's consistent difficulties in school, right? In their impact and functioning, right? So, and you should see some improvement if the child has ADHD with stimulant medications. With the first stimulant medication you try in a kid with ADHD, about 90% will show some improvement. Okay, if you try a second one, so you have an even greater chance of improvement. So you should see some changes with the medication and with services, with IEPs or 504 plans in the school setting. With cannabis, you're going to notice a kid whose development was kind of steady, and all of a sudden we start to deteriorate. We begin to have problems with attention, focus, and concentration. The symptoms tend to fluctuate, right? Instead of staying static as they would in ADHD. There's this deterioration, like we said, and we see this increased appetite. You know, when you're on stimulant medications for ADHD, the one main thing we watch besides sleep is appetite, because these medications can lower appetite. With cannabis, it tends to increase appetite. Just a few words on cyclic vomiting syndrome, because we've seen it on the inpatient unit recently. I've done call or worked on the inpatient unit since 2002 in this area, and I had not seen, or maybe we had not recognized, cyclic vomiting syndrome. I'd say over the last 2 to 3 years, we've seen quite a few cases. And so what you'll see is nausea, vomiting, abdominal pain. You'll see weight loss because of the inability to eat, because of the stomach cramps. You'll see dehydration. And the interesting thing that individuals will tell you is the only thing that makes this better is a hot shower. You see that sometimes in other conditions, but it's very common for the individual to say with cyclic vomiting syndrome induced by cannabis. Few words on EVALI. We talked about the CDC and FDA recommend to teens that people do not use THC containing e-cigarettes or vaping products because of the number of hospitalized and deaths. Vitamin E acetate is added to the e-cigarettes and with THC, which may be the culprit for these hospitalizations and this pulmonary syndrome that happens. There have also in D. Philippes and his colleagues, this was a recent study by the American American College of Cardiology. It was in their journal talking about the cardiac syndromes associated with cannabis, either intoxication or withdrawal or long-term use. There have been case reports on ischemic cardiovascular accidents, orthostatic hypotension, seizures, vasculitis, AFib, MIs, and inflammatory conditions. So what about driving? Driving is the other issue, especially in teens just learning how to drive. Studies, it shows it impairs lane changing. And these studies were done with not kids, but this study in particular was done with individuals who are adults who were impaired in a controlled setting. And they measured their reaction time and their attention in lane changing, and all of that was impaired. An interesting thing is, and something to worry about with these new drivers, 12th graders, when surveyed, they said about 10.3% of them said, yeah, in the past month, or the past 2 weeks, the past 2 weeks, I have driven under the influence of cannabis. So that's something we need to worry about. Also drivers, and this is by the National Institute of Drug Awareness in 2016, did another survey looking at fatal crashes and studying those, and they found that THC was in the blood twice as likely to be in the blood of people who were responsible for a fatal crash than those without. And cannabis use prior to age 16 has been linked to more motor vehicle accidents, even when not intoxicated. So what does that mean? We're looking at the long-term effects of cannabis on IQ, working memory, processing speed, and attention. The jury is still out, but there may be effects in the brain that is developing so quickly at this time during the teen years on these things. And it does seem that the long-term effects of IQ in some studies it has stayed after use, In other studies, IQ rebounds, but working memory, processing speed, attention seem like there can be long-term sequelae as well. So how do we identify cannabis use in kids or teens and adolescents? We screen for it. We look for a child acting out of character or a change in the way they're acting. We look for the new words, kids texting with their friends, talking about butter and spice and those kind of things. We look for increased irritability, these frequent mood fluctuations and changes. We look for this anhedonia or loss of interest in activities, kind of satisfied to just hang out. We have to look at their peer groups. We have to look at them very carefully because usually they're hanging out when they're able to, when there's no COVID, with people who are doing like things. So we look at that. We look at their memory, attention, focus, and concentration difficulties, especially if they're new, if it's not neurodevelopmental in nature, if they were not born with it, it's something that should sort of be a red flag to us. Well, there's something else going on here. If we find any paraphernalia, papers, bongs, lots of lighters will be very commonly found. If we see kids binge eating, if we see scleral injection or conjunctival injection, red eyes, and then stealing is also common in order to obtain the money to purchase the cannabis. There are some positive factors that are protective that we always try to enhance as much as possible. One of those things is family support and monitoring, keeping a close eye on the teens and knowing where they're at and what they're doing. If a teenager has peer acceptance, if they feel good about themselves, they're more likely to be able to resist the temptation to use substances at all, but especially cannabis. If they are satisfied with their appearance, so if they like the way they look and they feel about themselves, that is a protective factor. This feeling of competence, we try and get teens and kids involved in something where they feel good about themselves. This is especially important for kids who have ADHD or a learning disability who don't feel confident at school. So if there's a sport, a musical talent, art, something like that, where they can really feel competent or good about something, that can be a protective factor, and it can be even life-saving in some cases, especially with warding off thoughts of suicide. Supervision, like we said, monitoring in a positive peer group. Yes, it's hard for parents to pick their kids' friends. I have 2 adult sons and I'm raising 2 daughters now, and that's a tough thing. And it's a tough thing to always know what's going on. So treatment approach, how do we treat? Well, we screen, we determine the frequency of use, we screen for any comorbid psychiatric conditions. We will treat those psychiatric conditions. We know that abstinence is best, to not use at all, especially in this time when your brain is developing so fast. It's probably best not to use, but if we can't get that to happen, we try to delay use. If we can't get that to happen, we try to make it as infrequent as possible. We provide psychoeducation on the risks and benefits to parents and children. We discuss the patient's current symptoms, what can be attributed to cannabis use, what can be attributed to other psychiatric conditions, what is both, why are they using, how can we help them to use something that may be more beneficial to them. We discuss potential of addiction. We discuss future goals, like what do you want to be when you grow up? And how would marijuana fit into that? How would you be if you want to become a surgeon? How is that going to be possible if you're smoking all the time? What are you going to do? How are we going to do this? How are we going to work together to get you off? Always treating the comorbid psychiatric conditions. Weigh the risks and benefits of prescribing a controlled substance, not advised if they're actively using and not deciding to quit. Discuss the combination. You'll see kids from time to time who will say, oh, I'm going to skip my SSRI and I'm going to skip it so that I can smoke. So talking to them really about their medications and in the use of cannabis and how you want to take your SSRI every day for maximum efficacy. Also monitoring if MAPS with anyone who has been using or uses substances, any kind of controlled substances. Urine drug screens can be used. You can do random monitoring. You can do scheduled Both can be helpful, especially with teens. Remembering that the urine may stay positive for THC up to 30 days after use, especially with regular use. And so it's important to have just open conversations. I will say to the teens I'm treating, hey, if I tested you for cannabis today, what's going to happen? They'll say, well, I used it 2 weeks ago. Dr. That's probably going to come back. Okay, well then if we're going to make that pact to stay off of cannabis or stay off marijuana right now, then let's test you in a month and see where you're at, so kind of having that conversation. Here are some resources. These will be included to look at. I think Facts for Family by the American Academy of Child and Adolescent Psychiatry is really good. And these are the references if you want to look up any of those studies. Okay, it looks like we had some questions here. We have a few minutes. I'm trying to get to them. Chat, here we go. Okay, about downloading. Okay, so here's a question. Given the research, how do we counter arguments from those who insist marijuana helps decrease anxiety and depression? I think we tell them what we know, especially in teens. You kind of have the ability to say, hey, look, this is what's happening in your brain. Your brain is growing faster and becoming more efficient now than it will ever be. You want to save as much capacity of your brain. You want to make it as efficient as possible. Marijuana gets in there and it confuses the system. If you're a gardener, you don't know which are the weeds and which are the flowers you want to keep, right? And so it confuses, and you talk to them about them. I will show patients literature. We'll read it together. That's another thing we'll do. I'll talk to parents. Oftentimes parents think it's fine or it's good for you or it's helped me with my anxiety. Also reminding parents, you cannot smoke with kids. That's illegal. Kids should not have this, just as kids should not have alcohol, just as by and large kids should not have benzodiazepines unless they're going in for a procedure one time. These modify the brain and change it, and we think long term. Any potential problems between sativa and indica? Right now, there's so many other contaminants and there's so many compounds that it's hard to say if something is definitely sativa or indica. I mentioned the case that I had of the young woman who switched from one to the other and became acutely psychotic. There have been other case reports of switching, but it's really hard to say because we don't actually know what we're dealing with in any case. Okay. Don't know if there's any other questions. Lots of things about handouts and downloading. So
Could I just ask?
yes.
So how long, like as far as like the side effects, like which that are similar to ADHD and that. So like if you smoked it today, like how long, if you stop smoking, is that something that is like a long-term thing? Like it affects the brain long-term and you could have that kind of issue for the rest of your life? Or is it only like while it's in your system kind of?
Well, while it's in your system, it's worse. And so there's a ton of factors, right? And we don't know the answer. Some of the studies that show processing speed, working memory, those things seem to be impacted for a period of time, at least months, okay? So we know that the first month is sort of the acute withdrawal period. First 7 days, symptoms are probably worse. First 48 hours, cravings are high. After that, it seems to slowly titrate out of your system.
Mm-hmm.
If you've used it at a critical period of development, okay, from age 13 to 25, where your brain is developing as fast or faster than it was when you were an infant, it can impact these areas. And it can, we think, have long-term sequelae. The most common thing that's seen is this amotivational syndrome, but also these problems with processing speed and working memory. Remember, you're not laying down normal memory. That's why time passes funny when you're high on marijuana, right? You don't know if an hour's passed or 20 minutes or 5 hours, right? So your memories, you're not, those memories aren't being laid down. So your brain is developing so fast, you're in need of developing memories and schemas and all of those things. And it just isn't functioning normally at that point, right? So your brain isn't, since it's not functioning normally, it's not integrating information normally either. I don't know if that answers your question, but it was a good question. Other questions?
Do we have
Okay.
if you have any other questions, please feel free to unmute your line and ask the question verbally. Otherwise, please feel free to put it into the chat box and we can get those questions answered for you.
Yeah, in Victoria, was there some sort of handout, or they can get this online?
Yep, they can. You can get the copy of the presentation in PDF format. It's posted on our website. The link is posted in the chat box. That was what people were talking about.
Okay.
The link.
Okay.
So the handouts are located on the MCRH website in PDF format. So if you can look at the references here that Dr. Lay was referencing to in her presentation. But please feel free to ask our presenter any questions. And yeah.
Yeah, and the resources guide, the facts for families, if you're seeing kids or children, adolescents, those are really good, and they can be handouts printed off and given to families. National Institute of Drug Awareness has a lot of things. They have guides for teens as well as parents. So I think those are really helpful as well. Remember, lots of people will come to you and they'll say, well, I looked it up and I did my research and this is what it says. You can find almost anything to support any opinion. So what we want people to do is really look at the literature and what we do know now. It may turn out 10 years from now, there may be a good use for THC. We don't know what that is yet, right? And what we're seeing in psychiatry, and since it's so unregulated, we don't really know what somebody's getting, and the impacts we're seeing by and large in psychiatry are negative.
Great.
Other questions?
Great information for everybody. If you have any questions or comments for our presenter, please feel free to put them in the chat box or unmute your line. I know it is a few minutes past our 1 o'clock hour, so if you don't have any questions or comments, we can go ahead and sign off. I will be emailing out the evaluation here in a little bit. And if you feel free to indicate your questions to our presenter on your evaluation, or you can email them directly to me and I can pass them along to our presenter that way as well.
And I know it was a lot of information. I meant to be very inclusive so that you have it to take with you wherever you're practicing.
Okay. Thank you, everybody. It looks like we don't have any other questions. We're just getting a lot of great presentations, and thank you. Thank you. Thank you.
You're welcome.
Okay.
And Victoria, we can chat, and if there's any other questions, I'll be happy to answer those for anybody.
Yep. Thank you.
Thank you.